Hi everybody, and welcome to our webinar this evening on COVID-19 immunity, vaccines and risks for people living with MS with Professor Kingston Mills. Some of you may remember that in 2020 we did a webinar with the same title, and we were just a few months into the pandemic at that stage. And now we wanted to revisit this topic to understand where we find ourselves in 2022. There's been a lot of change, public health measures are easing, and we feel it's important to understand where we are now. So we're absolutely delighted to have Professor Kingston Mills with us this evening to present. Kingston Mills is a professor of experimental immunology in the School of Biochemistry and Immunology in Trinity College Dublin. He is Academic Director of Trinity Biomedical Sciences Institute and is the TCD Research Champion for Immunology, Inflammation and Infection. Professor Mills is also the co-lead of the Trinity COVID-19 Research Hub, so who better to talk to us about this evening. And just before I hand you over, I wanted to say that we did receive a large volume of questions in advance. However, our chat box is open, so if you have questions throughout, you can send them through to us and we will try to answer as many questions as we possibly can towards the end of the session. We are going to record the session as well, so if for any reason you miss any of it or you want to revisit it, it will be on the website in the next few days. So with that, I'm going to hand you over very quickly to Professor Mills. Professor Mills, thanks so much.
Thanks very much, Aoife, and to MS Ireland for inviting me to give this webinar. I'm delighted to do it again. And those of you who may or may not have heard me in the media, I have been very supportive of the situation that people like yourselves find yourself in right now. And I think I was saying in advance of this that the mood has changed very much nationally in that people are want to get back to their normal lives, but sometimes they forget there are people that may still be vulnerable. So that's an important aspect that I'll address in this talk. Some of the slides are similar to what I showed in the 2020 webinar, but some, obviously a lot are new because everything has changed. First of all, a disclaimer, I'm not a medic, I'm a scientist, and I cannot advise anybody on treatment or diagnosis or any other aspect of their medical condition. So it's important to make that disclaimer to start with. This is a modified version of the slide I showed last time, just to explain to people what COVID-19 is. COVID-19 is a disease caused by the virus, SARS-CoV-2. Not everybody that gets infected with SARS-CoV-2 actually gets disease. In fact, 50% of people who get infected don't have any symptoms at all. But those people can still pass it on. And that's been part of the problem throughout the pandemic, not diagnosing what we call asymptomatics, and then finding that they're transmitting it. Now, we obviously have heard about the emergence of Omicron, the latest variant, and there's BA2 subvariant. And this has changed a lot. The disease was very severe, and that's bit of the slide on the right illustrated the severity, the various organs that can get involved, not just the lung. People think this is a lung disease. It can also affect the organs outside of the respiratory tract. And you get these acute cytokine storms, which can cause, systemic inflammation. The good news is that with the arrival of Omicron, the numbers of people being hospitalized, going into ICU and dying from this considerably reduced. 20%, 2%, and 1% is going down to 1.2 and 0.06. And the latter is statistics from January. It may even be lower than that because it wasn't entirely based on Omicron in January. It would still be remnants of Delta. The big risk factors are age, over 70, underlying medical conditions like obesity, type 2 diabetes, cardiovascular diseases. There's a thrombosis aspect to severe COVID, which is exacerbated in people that have thrombotic diseases. Sorry about the sort of detail on this slide. This is sort of an immunology aspect of the disease. On the left, we have the mild disease, which is mainly an upper respiratory tract infection. This would be the Omicron type disease, which is very well contained by the immune system, by antibodies if you're vaccinated or previously infected, by cells of the immune system called T cells, which kill virus-infected cells. On the right, the more severe disease, where you have a very active immune responses, very high viral load. You get the systemic inflammation, so the cells that are attacking the virus actually leave the lung and go into the circulation, and even go into the heart and kidneys and liver, and even to the brain, and cause neurological complications as well as organ damage, encephalitis, encephalopathy, and even cognitive issues. And we've heard about long COVID. Well, long COVID is part of all of this, due to the fact that the virus disseminates away from the lung. Now, let's put Omicron into perspective. As I said, it is less pathogenic. You get less lung infection and more upper respiratory tract infection. And as I said already, the numbers of hospitalizations, ICUs, admissions, and deaths are considerably reduced compared with the previous versions, the Delta and the Alpha versions of the virus. And this data on the right shows that it's more transmissible because it binds more readily. The virus binds more readily to the bronchus. That's the tube that takes your air from your nasal cavity and mouth down to the lungs than it is in the lungs. So this just shows that the replication of the virus is higher in the bronchus with Omicron than it was with Delta or the original strain, whereas in the lung it's lower. And that's consistent with the fact you get an upper respiratory tract infection, which means that the infection is less severe, because it's more like, I wouldn't say it's like a cold, but analogous to a cold than a sort of a flu-like illness that you get, or even worse with the deep infection in the lungs that you've got with Delta and the earlier versions of the virus. The last thing which I'll deal with in a bit of detail is it evades immunity better than so the vaccines don't work as well against this variant than they do against earlier variants, and I come back to that. So where are we at with this Omicron variant? And the latest one now is this BA.2 variant, which you might have heard about. BA.2 is a sub-lineage or sub-variant of Omicron. And the slides on the left here show, and they're a little bit out of date. I mean, this is only the end of January, so it's a month on from here. In Denmark, this was Delta in the yellow color or the orange color. And this was a BA.1, the Omicron, the original Omicron variant, which peaked in Denmark in early January. But now what's happened is BA.2 has taken over in Denmark, and it's the dominant type. And the same is happening in South Africa. In the UK, this again is much behind time, and in Ireland. In Ireland now, Omicron is probably, we don't know the exact figures, but I heard that it was 40% a few days ago and rising by 10% a day. So it's probably already the dominant variant in Ireland. The lab studies suggest that it, as I said already, it's more transmissible. And the fact that it's pushing out the original Omicron suggests that it's more transmissible. There is some lab studies from Japan to say in animal models that it caused more severe disease, but that's not been borne out by real world data yet. So it seems like it may not be more severe, but for certain it does evade immunity better than Omicron. And it's also may evade immunity generated by BA.1, the original variant. So if you're infected with Omicron, you're not necessarily protected against BA.2, and that's not good news. But the vaccines, the bottom line is that 3 doses of the vaccines, especially if the person has also been infected, gives very good protection against severe disease with Omicron or BA.2. And I'll come back to this when I talk about vaccines a little later. In terms of transmission of the virus, this is old news now, but just to go over it again, there's an incubation period of the virus where it's not really detectable, and then it's an infectious period where the person starts showing symptoms and then recovery. Now, this is much truncated in somebody who has partial immunity by vaccination or previous infection. This would be in a person who has no immunity. It can be spread in the pre-symptomatic phase. So in this phase here, before the person starts showing symptoms, that person could pass on the virus to somebody else. It's spread by coughing and sneezing. So, you know, when you cough, sneeze, or even talk loudly without wearing a mask, it's very easy to spread this virus. So we know that in household contact settings, people transmit the virus very readily to those that are not immune around them. And transmission is very high in indoor settings. It's less of an issue outdoors. In terms of testing, this is sort of old news now. I was part of 2 antigen testing groups that reported to the Minister for Health, and one of them sat in February of 2021 and chaired by Mark Ferguson. And we recommended antigen testing as early as February of last year. And then a second group on the implementation of testing that Mary Horgan chaired, it reported in October, November, and we also recommended implementation. And eventually it was implemented. And now, of course, everybody in the country has done antigen tests, and they're a huge, useful way of, easy, simple, cheap diagnosis of this infection. And the point about them is that they diagnose it when you're at the peak of infection, when you're at this stage where you're at the peak of the virus, when you're most likely to be transmitting your antigen test positive. Whereas the PCR is very sensitive, it's still detecting it after some of the symptoms have even gone. So it's actually picking up people that may not be transmitting the virus. So in a way, even though it's the gold standard, as everyone keeps saying, the antigen tests are very, very useful. So where are we at? This is the slide I showed. This is the slide, it's not the one I showed in 2020, but it's from exactly a year ago, the 23rd of February, 2021. This is taken from the New York Times website. New York Times is a very good website on COVID and COVID vaccines. And as you can see, this was the global spread. And I don't know if you can see that on the bottom, but there's this is in number of cases per 100,000 people. And if you're in the sort of dark red going into black almost, then it's very severe. But there's only a tiny number of countries at that stage, mainly in Eastern Europe, that were in that category. Fast forward a year, and this is the color on the same scale, the same color scale. You can see even today, even though we say it's all over, this is the situation in the world. All of Northern Europe, Western Europe, the whole of Europe, Russia, North America, but not, and some of Southeast Asia is got very, very high case numbers still. I mean, we say they're low because they're low relative to where they were in January, but they're not low compared with what they were in 2021. And of course, it's very mild, so the disease, so the hospitalizations are not as seriously affected, and I'll show you that now for Ireland. These are the case numbers and the deaths in Ireland over the entire pandemic. And as you can see, we had tiny case numbers in the first wave in early 2020, but a huge number of deaths. And that was because the virus was very pathogenic. We didn't know how to treat it, and a lot of people died. And then in the second wave, the second big wave in late 2020, early 2021, again, a lot of people died, and there were a lot of cases, up to 1,000 cases, more than 1,000 cases a day. The peak was actually 6,000. And then, of course, we had various mini waves, one in the end of August, September, but then the huge one, of course, the end of this year, the end of last year, the beginning of this year, where it went up as high as 20,000 cases. And then 20,000 cases is a complete underestimate. It was probably 50,000. The death rate didn't match that, but nevertheless, the death rate is still running at between 60 and 100 per week. And that's not trivial. So a lot of these are people with underlying medical conditions, older people who are, and people say Omicron doesn't kill. Unfortunately, it does. And a small number of people are still dying from Delta because Delta is still having an influence. But some of these deaths that recently occurred are from Omicron. So even though the case numbers have come down and the death numbers are much lower, comparatively lower, it's the really important thing is the ratio between the numbers of cases and the deaths is now completely different than it was in the last two major waves. These are the hospitalizations and ICU admissions. And as you can see, in the second wave, we had huge number of hospitalizations, huge number of ICU admissions. The hospital admissions went up and the ICUs with the current wave, but they've come down significantly now, especially the ICU admissions. I think it's at 50 at the moment, 50 people in ICU right now, or thereabouts. And the numbers in hospital is also declining to around 500. So, we're in a much better place. And the good thing about that, it's allowing the hospitals to get back to treating diseases that should have been treated all along, but couldn't be because of the pressure on the healthcare system. Of these 500 or so that are in hospital, more than half of them go into hospital without COVID, without knowing they have COVID. They get diagnosed in hospital because everyone has to have a COVID test when they go in. And so they're not symptomatic with COVID. They're going in with other indications and they're turning up to be COVID positive. So that figure can be halved, because around half of them are not really COVID patients. They're other diseases and they just have to be diagnosed with SARS-CoV-2. In terms of the profile of ages, if you look on the left, this is the case, this is the cumulative cases. And as you can see, that the cumulative cases are highest in the age groups 15 to 44. So that's the sort of young population, late teenagers and 20s and 30s. If you now look at the hospitalization in the middle graph, you can see this and much more so in the older age group. But similarly, interesting to see that 700 children under the age of 4 were hospitalized. So it's not a trivial disease, even in the very young. And of course, most of those are attributed to the earlier variants like Delta, not so much Omicron. And the deaths, again, tend to be even more extremely in the older group, with the vast majority in the over 75 or over 85. But again, 10 deaths in under 24. So most of those deaths were in people with underlying medical conditions. This is putting Ireland into perspective of where we are with other countries in Europe and compared with the US. Ireland I've highlighted in yellow there. We peaked much earlier than most of the other European countries. Sorry, let me go back to that. And Ireland is more analogous to the UK, where we tend to go very much in parallel with the UK because of the border proximity with Northern Ireland and the fact there's a lot of travel between Ireland and Britain. So whatever we get, they get, and whatever they get, we get, more or less, or certainly what they get, we get. But if you look at a country like Denmark has the highest case numbers still, followed closely by the Netherlands, although they are dropping now in Denmark. And that's partly because Denmark was the first country really to suffer from the BA.2 variant. And it had huge numbers, as did the Netherlands. But all of these countries are now declining. People say the US has been the worst. Well, in fact, the US has less cases per 100,000 people right now than Ireland has. So we're pretty good in Europe. We're pretty much close to the bottom in terms of case numbers. But of course, all of this is very artificial because it depends on how well a country actually diagnoses. And now Ireland, of course, and most countries are going to chuck the testing part more or less, except for people in older age categories or that are in certain high-risk groups. So coming to the immunology of this, how does the immune system, I need to tell you about this to explain the vaccines, which I'm coming to. And also a couple of interesting things from the MS perspective, because one of the ways that we have an innate immune system, we have an adaptive immune system. The innate immune system on the left includes cells, but also molecules. Interestingly, a molecule called type 1 interferon. And you might be aware, of course, that one of the leading drugs to treat multiple sclerosis is type 1 interferons. So it's the same drug that's effective at, they're not exactly the same, but similar, the same molecule that has antiviral properties is also used to treat MS patients as a therapeutic. So that's interesting. So, when I come to the last slide of the presentation, the take-home message is that interferon treatments are not going to compromise your ability to cope with SARS-CoV-2 if you're unlucky enough to get it. In fact, it could be the opposite, that it may be beneficial because interferons are antiviral. Our cells of our adaptive immune system include the T cells, and these are killer cells which kill virus-infected cells. So they reduce the viral load by killing the cells that allow the multiplication of the virus. Now, the virus gets into cells through this receptor called ACE2, which is expressed on the airways. And the antibodies that bind to the spike protein on the virus stop it getting to the ACE. So that's the basis of what what I'm going to talk about in a minute, which are these neutralizing antibodies that the vaccines induce. So vaccines have been the big success story of COVID-19. We have this again, the bottom collage is taken from the New York Times website. We have 12 vaccines that have been approved, 16 that have been authorized, which is sort of pre-approval. Only 11 have been abandoned. And then there's another nearly 100 that are in various stages of preclinical development and clinical trials. So it's been a phenomenal success story in terms of the numbers of successful vaccines that have been generated, developed, and utilized so quickly. All of the vaccines are designed to target, or most of them, 99% of them, the spike protein, which is the surface protein of the virus, that bit that binds to the receptor on the cells. Normally, when we make a new vaccine, it can take 5 to 10 years, and there's various steps in the process, identifying the antigens, phase 1 trials, phase 2 clinical trials, phase 3 trials, then scaling up manufacturing and production. It can take 5 to 10 years. And with COVID, it took a year. Incredible. I mean, just because of the emergency and the money that was pumped into it by government, largely US government has to be said, and by the companies themselves. They really, and the scientists sort of feeding into this from all the research institutes around the world. It was a global effort to get this vaccine made, tested, and on the market within a year. It was incredible. So it's a success story of medicine that was a response to the problem. And I wouldn't say it solved the problem, but it's had a huge impact on the number of cases and number of deaths from COVID-19. So we've heard of various types of vaccines that are on the market. This is a sort of a teaching slide on the types of vaccines that are out there, not for COVID. This is just generally, first of all. So the most common vaccines probably are the live attenuated. These would, on the right, these will include where you weaken a virus or a bacteria and you give the person an infection with a bacteria or virus that doesn't cause disease. And this would include the measles, mumps, rubella, polio, BCG, flu, rotavirus, herpes. And then you have vaccines that are based on inactivating the virus. You kill the virus. So it's the same as this. Instead of being live, it's dead. And polio, flu, rabies are examples. Other one is to take a bit of the virus, the spike protein in case of SARS, or the HA for flu, and to make what's called a protein vaccine. And diphtheria, tetanus, pertussis, hepatitis B, Haemophilus influenza, pneumococcus, HPV, and meningococcus B are examples. So this is a new technology, but not that new. And then the most recent are either the recombinant viral vectors, and these would be, there's an Ebola vaccine that was made, never really used, and then the mRNA, which had never been used before SARS came along. So you'd have heard of the Moderna and the Pfizer-BioNTech vaccine, that's mRNA. The Oxford AstraZeneca and the Janssen are both adenovirus vector vaccine. And then the Novavax, which has just been put on the market in Ireland, this is a protein vaccine made with more traditional technology than the mRNA or the recombinant viruses, the viral vectors, that the adenovirus vectors. And then in Japan, in China, and in Russia, and in India, they've made a number of inactivated vaccines, which have worked quite well, it has to be said. And they're made up of the whole virus rather than just the spike protein. How does the vaccine work? All the vaccines practically on the market, or all of them on the market, in fact, some of the ones in development are not, but all on the market are injectable vaccines. They're injected into the muscle usually. The sort of macrophages and dendritic cells, these are cells of the innate immune system, take up the antigens from the vaccine, take them to a lymph node and prime the T and B cells. The B cells make the antibodies that stop the virus from binding to its receptor, these virus neutralizing antibodies, and the T cells can then, as I said before, kill virus infected cells. So there's a two-pronged approach to it. And then you get memory B and T cells laid down that gives you long-term protection. But one of the problems with the current vaccines is that they don't induce good memory, and that's going to be the second generation vaccines. The aim of an effective vaccine is to prevent disease, first of all, and thereby reduce or eliminate the need for admitting people to hospitals and deaths. The second aim is to prevent infection and to induce what we call sterilizing immunity in the respiratory tract, and then prevent what's called community transmission, so transmission from one person to another, and eventually to induce herd immunity in the whole population that would protect the vulnerable. And also to sustain that immunity for many months and even years. That's a longer term goal. And eventually to eliminate the pathogen, which of course has only been done with one vaccine, the smallpox vaccine. The first generation vaccines do one. So the current vaccines we have prevent disease. They don't prevent infection. They will not induce herd immunity. I'll come back to herd immunity in a minute. And they do not have long-term protection. So they need to be, we need to work on the second and third generation. And that research is ongoing, including some work in my own group, where we're looking at ways of making vaccines that induce sterilizing immunity and long-term protection. This is a little cartoon that explains how a vaccine works. Normally, when you get infected with a pathogen, whether that be SARS-CoV-2 or influenza, you get sick and recover, and then you're immune to subsequent infection with the same virus. If the virus changes, you won't be immune. And that's why we need to be vaccinated with flu every year to maintain immunity. And the same is the case with SARS. The virus is changing. So immunizing with the Wuhan strain doesn't necessarily protect against Delta or Omicron. Now, the other way of doing that is to, instead of infecting you, is to inject something that induces the same response as infection, but doesn't cause disease. And that's the whole advantage of a vaccine. You can get immunity without disease. And then what the holy grail is to get this thing called population or herd immunity, where there's a threshold that has to be reached where a percentage of the population, and it's probably around 90, people said it was between 80 and 90% for SARS initially, but I think most people agree now is around 95%. So 95% of the entire population, including children, would have to be immune to the circulating variant before we would have herd immunity. And the big deal about herd immunity is that it protects people who mightn't themselves respond very effectively to a vaccine. So somebody in anti-B cell therapy, for example, that won't respond as well to a vaccine will be protected because everybody around them is protected. And therefore, by being part of that community, they're not susceptible. Now, in terms of Ireland, on the 10th of December 2021, which is only 2 months ago, or a little over, we had 60,000 confirmed cases of COVID-19 in Ireland. 2 days ago, we had 1.2 million. So that doubled in the space of just over 2 months. That's the official numbers. And that's 26% of the entire population. The unofficial numbers probably are double that. So I would say that at least half the population of Ireland have been infected. Now, some of those have been infected with Omicron. Some have more recently been infected with BA2, but a significant number also got Delta. So in terms of herd immunity, the people that got infected with Delta and maybe even BA2, BA1 may not be sufficient to confer protection against BA2, which is now going to be the dominant strain. So it will need the vaccine as well as the infection to get to the level of immunity we need to get good population immunity. But having said all that, vaccines have a huge impact. This is some data from from Israel, which showed the benefit of vaccines in terms of infections. The upper line is the sort of the unvaccinated, the blue lower line, the solid line are those that have received the vaccine. In terms of the number of cases, the number of hospitalizations, and the numbers of deaths. So the Israelis have estimated that they've averted 100,000 infections, and this is really old data now, back to May 2021, 20,000 hospitalizations and over 4,000 deaths from COVID-19 as a result of vaccination. And in the US, the statistics are even more staggering. They reckon they've saved 279,000 deaths, and that was by September 21. It's probably dramatically more than that now. So probably 500,000 or more deaths have been averted in the US as a direct result of vaccination. So I don't need to sell vaccines anymore to you. I think I think everyone gets it that vaccines have been hugely important in controlling this pandemic. that was the good news. The sort of slightly more disturbing news is what's happening now with Omicron. With Delta, the vaccines, 2 doses were pretty effective. Even up to 5 months, you had 77% efficacy. And with 3 doses, it was up to 90%. But when Omicron came along, that had dropped to 37% after 2 doses and to as low as 31% 5 months after 3 doses. So you're getting, really a level where even 3 doses of a vaccine is not that effective after 5 months. And that's why the Israelis went and gave a 4th dose of the vaccine, especially to the vulnerable. And then looking at the benefits of previous infection on the right, if you had previous infection with alpha, you're going to get 90% infection, 90% protection against symptomatic disease and 70% against severe or fatal disease. But against Omicron, which is the one that's circulating now, about 88% efficacy of Omicron versus Omicron, but only 56% against symptomatic infection. And the bottom line is that both BA2, the emergence of BA2 and Omicron, make it more difficult for previous infection to confer immunity against reinfection. Again, I'm sorry about the data here, but it's quite simple to follow. These are levels of neutralizing antibody, which are a sort of a proxy of protection that people use to say whether somebody is likely to be protected. If you've got neutralizing antibodies against the virus that are high, you're likely to be protected. And this is for the Mrna vaccine. And they're comparing the antibodies against the original strain versus Omicron. The original one is in black, and you can see after 1 month after the 2nd dose, you've got high levels against the original strain, but much lower levels against Omicron. And after 7 months, they both waned, and this is now critically low to the threshold that would be considered to be protective. But if you give a booster, that goes back up again, and then 6 months after the booster, it comes back down, and it's down further against Omicron compared with what it would be against Delta or its predecessor. So again, the vaccines are struggling because of the emergence of these variants. Hesitancy is a big issue as well. And, we had great uptake of vaccines in Ireland until December. And now the vaccine, especially for the boosters, has fallen off. And I've taken this quote from Jessica Doyle in the House of the Oireachtas, and she said that confidence, complacency, and convenience are the reasons for hesitancy. So if you lack confidence in the vaccine, or if you're complacent about it, or you couldn't be bothered, which is the case with some people, believe it or not, they just couldn't be bothered going to the vaccine centres, then the uptake goes down. And these pie charts on the right show the results of polls made by the Irish Pharmaceutical Healthcare Association. Early on in June 2020, shortly before the vaccines were licensed, 73% of people were in favor of them. But then in June, they were still being developed. In October, they were about to be licensed. People were getting a bit hesitant about it, and it dropped to 55%. But then in February of 2021, it went back up again. And by December of last year, 93% of people in Ireland said they would have a vaccine. So there was huge buy-in. Now, I haven't seen any more recent polls than this one, but I imagine if there's a poll done now, that level may have dropped again. It may not be hesitancy. It may be this convenience thing, or think that the problem has gone away and we don't need to do anything about it. It's also to do with incentives, because one of the thing that I've spoken in favor of is the vaccine certs as a means of making places safer, but also of encouraging people to get vaccinated. And they're now, of course, gone. And that removes an incentive for people to get vaccinated. And I think that's part of the issue with reduced uptake of the booster vaccines. Another thing is the mRNA vaccines. People were suspicious of them because they're new, but there's now a new vaccine on the market called the Novavax vaccine, which is made with traditional technology. And people who are concerned about mRNA vaccines can get the Novavax vaccine, and it's just as effective, if not more effective, and it solves the problem of not being a new type technology. I don't think the authorities here have made that clear enough to the public maybe they're afraid that people will drop the mRNA vaccines. I don't know the reason. The other sort of good and bad news, and I'll give both sides to the story because I always try to be honest about things, is the therapies. There's some very good news here, and there's also some, maybe not so good. So there's three types of therapies for COVID-19. One is the antibody therapy, where you give antibodies in an injectable form. These are antibodies that are made in the lab. GSK, GlaxoSmithKline, and Regeneron both have antibodies which have been licensed for use in Europe. And the GSK one, Xevudy, is now available in Ireland. But I'll come back to whether it works or not in a minute. Antiviral drugs, including Paxlovid, Remdesivir, and Merck's drug, all show good efficacy, especially Paxlovid, and I'll come back to Paxlovid as well. These are designed for high-risk individuals. Anti-inflammatory drugs, these have changed treatment of COVID dramatically, especially dexamethasone, but a simple steroid, but also antithrombotic drugs, which weren't used early on, are now used to treat most COVID patients, and they're very effective. In terms of the monoclonal antibodies, this is the result of the Regeneron, a company that has a base in Limerick, makes these antibodies, and they look to be fantastic in the clinical trial. But the clinical trial was done against Delta, or Delta was prevalent when it was being tested. And it was 100% effective at preventing infection. A single subcutaneous injection of this antibody cocktail prevented 100% of people getting symptomatic SARS-CoV-2 for up to 5 months. And all infections, including asymptomatic, by 89%. But after 8 months, that had dropped a bit, but it was still pretty good. So that really looked like it was working. And then along came Omicron and BA2. And I'm sorry, again, this is a detailed slide, but it's quite easy to follow it. So these lines are connecting the titers of neutralizing antibody that are generated against either an original variant, the BA1 or the BA2. The ones you want to look at are the ones in green and the blue one. And these are for people on the left that have been vaccinated with mRNA vaccines, or on the right, people who have recovered from infection. And the threshold line here is a line where you consider you might be protected. And what you can see as BA1 and BA2 emerge, the levels of antibodies are very weak against these variants, below the threshold level. But if you got infected and had the vaccine, as is shown here in this one, you can see that there is good level of protection. And if you got boosted as well, there's good levels, even against the Omicron, there's a good level of protection. Now on the bottom, it shows the monoclonal antibodies from both GSK and Regeneron. And the bottom line is that the combination of antibodies from which are called sotrovimab and medivimab, this combination do retain some efficacy against BA2, but it's reduced. Whereas the GSK antibody, the one that's available here, is ineffective now against BA2. So even though it's on the market here, I don't know if it's going to be used or if it's going to be any use against BA2. That's what this data is suggesting, at least. But the Regeneron one, which has been licensed for use in Europe, still retains some effects. This is another study done in another lab, and they looked at similar results, and the bottom line was the same, that in the BA1 and the BA2, the ability of the vaccines to produce antibodies that protected against those variants was declined. And again, the monoclonal antibodies, the ones from Regeneron, had some efficacy, but the GSK ones, the efficacy was reduced. So it means that these monoclonal antibodies are struggling to contain the virus. They're shown a slightly different way. This is the reduction in the numbers of cells that are infected. So against BA1, it's working, but against BA2, it's not working. Whereas here, you're getting mild benefits, but it's not huge. But the good news is that Paxlovid, this antiviral drug, is very effective. It reduces, the clinical trials showed that it reduced the symptoms and hospitalization by as much as 90% if it's given within 3 days of symptoms onset. Only 1% of patients who received the drug were hospitalized compared with 6.7% in the placebo. This was done in the Delta era, but because it targets the polymerase gene, which is an internal, not a variable part of the virus, it's not affected by the mutations that occurred in Omicron or BA2. So it should still work as effectively against Omicron or BA2. It's an oral drug. It's given twice a day for 5 days. It has to be given within 5 days, preferably 3 days of onset of symptoms, and it will be available in Ireland. And the HSE have said by the end of February. It's not clear how it's going to be prescribed, whether it's going to be by GPs or in hospitals. It's an oral drug, so it could, in theory, be prescribed by GPs. So coming to the last bit and what it means for people with MS and other autoimmune diseases. Disease itself shouldn't make a person, MS, a disease, shouldn't make a person more susceptible to infection with SARS-CoV-2. It's really the drugs you're on that will make you more susceptible, not the disease itself. There is a theoretical risk of enhanced inflammation, but that's sort of gone out the window now because the inflammation is no longer a big issue since the arrival of Omicron. The biggest risk factor really is obesity. So obesity is probably the untalked about huge risk factor for COVID-19, not for getting infected, but for getting severe disease. And again, that was more with the pre-Omicron variants than with Omicron. Interferon beta, as I mentioned before, it's antiviral, anti-inflammatory. They actually trialed it in treating COVID. Wasn't that great, it has to be said, but certainly doesn't exacerbate the disease. Immunosuppressive therapies are another thing. They're shown to increase infection, that we know, and I'll show you which ones on the next slide. But on the other hand, some of the immunosuppressive therapies that are used to treat autoimmune diseases, such as this anti-IL-6 antibody that's mainly used to treat rheumatoid arthritis, has been trialed as a treatment for COVID-19, because what it does, it stops that immune response. In a way, some of the symptoms of COVID-19 have parallels with some of the symptoms of MS and other autoimmune diseases, uncontrolled inflammation or parts of the immune system that's out of control that can be controlled by drugs. So that's why similar drugs have been tested. This rather detailed slide, which I sort of leave it with you rather than go through it in major detail. But the bottom line is the interferons, there should be no evidence of any increased infectivity. Glutaminyl acid or Copaxone, no evidence of it. All of the others, there is some evidence. So some that are doubtful, like the Tysabri or natalizumab, which is blocks. I'll show you how it works on the last slide, but there is some evidence that increases susceptibility of the brain to viral infections. And with all the others, the Gilnea and all the more recent ones, in particular the last family, the anti-CD20 that target the B cells, they all reduce the vaccine response because the vaccines work by making antibodies produced by the B cells. So if you knock out B cell function, you're going to reduce the antibody response. So patients are always advised to not to get vaccinated a long time after they've had their last course of treatment of the anti-B cell therapy to give the immune system a chance to recover and respond to the B cell. B cells respond by making antibody. This sort of puts in one slide the my cellular immunologist's layman's, well, semi-lay interpretation of what might be happening in MS and where the greatest drugs targeted. It all starts with damage and infection. And there was a paper published recently, a few weeks ago, which showed that there was a very strong correlation between Epstein-Barr virus infection and multiple sclerosis. So people who had multiple sclerosis were more likely to have Epstein-Barr virus infection. So it was adding weight to this theory that disease is precipitated by infection. Other people think it's by damage, you know, what they call sterile inflammation. All of this drives innate responses, which activate T cells to leave the lymph node, go into the circulation, cross the blood-brain barrier, go into the brain and the spinal cord, And these, particularly these Th17 cells, produce the cytokine IL-17, and the B cells as well. They help the Th17, and that's why B cell therapy is a very effective therapy now for certain types of MS. So where are the drug targets? The first one is FTY720. It's a scientific name, but these are two drugs, or Gilnea is the one you're probably most familiar with, that blocks egress of lymphocytes from the lymph node. These are drugs that stop the pathogenic, the disease-causing cells get into the brain. Now, these drugs may have some impact on SARS-CoV-2 because they will also stop the T cells leaving the lymph node to go to the lung, where they will help to fight the infection. The other drugs, such as Tysabri, which stops the T cell going across the blood-brain barrier, these are very effective drugs, but they do leave the person slightly susceptible to some infections, and there might be a suggestion that they might affect, your ability to cope with SARS-CoV-2 infection. And then there's a series of drugs that target the T cell itself, the Th17 cell that causes the damage, and these are or the cobaxone, which induces immune regulation that blocks this. So these up the immune regulation. These are regulatory responses, and if you over activate the regulatory responses, you take away the damage-causing T cell, but you also take away the T cell that fights infection. So there's a slight risk with these drugs that they may reduce person's response to the virus as well as to their disease. So I think I'll leave it at that, and those slides will be available, I think, or at least the recorded webinar will be available for you to see. And I'll stop sharing my screen. I'm happy to take questions.
Great, Professor Mills, thank you so much. That was so informative, and especially in relation to the new subvariant. I think there wasn't a lot of information on that to date. Look, we have received a lot of questions, and I said there was a lot in advance as well. So we will use our time now to try and get to as many as we can. One is regarding B cell therapies and optimal booster time. So is there an effective time? So should it be given before or after the treatment?
It should definitely be given before the treatment. The booster should be given before the treatment, because once you give the anti-B cell therapy, you're going to take out the B cells, and they're the ones that need to respond to the vaccine to make the antibodies. So the longer interval you can have after the last treatment and before the next one to get your vaccine, and to wait a few days afterwards before getting the treatment, because it takes a few days, maybe 5 to 7 days after the vaccine, for the B cell function to make those antibodies. With the booster, it's quicker than the primary. With the primary vaccination, it takes up to 14 days to get a good response. With a booster, in 5 to 7 days, the B cells will have made the antibody.
Thank you. And there is a question about mixing vaccines and if it offers better protection. So for example, if somebody's primary vaccination was AstraZeneca, and let's say for some people then they would have received an extended primary of Pfizer, are they better off to get a Moderna booster?
Right, okay, so this is something that I was on a hobby horse about during the early part of 2021, when NIAC were very resistant to embrace heterologous vaccination, because what had been shown was that people in my age group were forced to take the AstraZeneca vaccine because we were in the sort of 60 to 70 age group, and myself and a lot of my colleagues were very annoyed by this, because we all could see the literature that the AstraZeneca vaccine just was not as effective as the mRNA vaccines. And then lots of studies were done where they boosted people that had the AstraZeneca with the other Moderna and Pfizer, and they showed huge benefits in terms of enhancing the responses. So this heterologous vaccination put the response back to, it would have been as good as giving 2 Modernas or 2 Pfizers. So eventually NIAC relented, and they agreed to it. So that was introduced, middle of last year. So yes, the answer, absolutely. Heterologous vaccination, giving a primary with one, a booster with not, there's no negative side of it. If anything, it's beneficial. And the other vaccine, Novavax, one that's going to be coming on the market soon, if I was going out tomorrow to get a booster, I would choose it, because I think that it's going to give slightly better memory than the mRNAs, whereas the mRNA were better than the adenovirus at inducing the antibody responses. So it's no problem at all mixing vaccines. There's no real serious side effect associated with it I'm aware of, other than what the normal side effects of these vaccines, and the benefit in terms of boosting the response, especially if you had an AstraZeneca early on or a Johnson & Johnson, are huge.
Thank you. A question here as well about what people living with MS can do to protect themselves. So we know that the FFP2 masks are, you know, a more effective mask for people to wear. Is there anything other than that people with MS, given that the restrictions or that, you know, the public health measures are easing from Monday, what can people with MS do to help themselves?
Yeah, I mean, one of the things about masks, the benefits of masks are much greater when everybody wears them. A person wearing a mask to protect themselves is not as effective as being in a room where everyone is wearing a mask. That's the first thing to say, just being very honest with you. But obviously wearing a mask is better than not wearing one, because you know it's to do with the fact that you're you know, when you're coughing and sneezing and you've got COVID, you know, if you're wearing a mask, you'll trap a lot of the virus in the mask. But whereas you're wearing the mask and you're trying to stop yourself from getting infected, if there's virus in the air, you know, sometimes you're just going to breathe the air down through the side of the mask. It's not foolproof in protecting you. It'll give you some protection. And certainly the FFP2 masks, they're readily available now. I mean, we've been given them in Trinity. We've been given them free because the Department of Health, or Department of Education rather, gave all the third level institutes free masks. So we've bucketfuls of them. I don't think they're ever going to be used. If anyone wants some, come in. FFP2 masks are also available in all pharmacies practically, and they're better than the cheap you know, ones you can pick up in the supermarkets.
Great, thank you. And is there a test people can have done to find out their level of immunity?
Yeah, I wish there was. Indirectly there is, but it's not going to be available to okay, let me start again. When you get vaccinated, you make antibodies, and I showed you those neutralizing antibodies and how they were dropping in the blood, and that's how you can test whether somebody is likely to be immune or not if they've got lots of neutralizing antibodies. It's not a trivial test to do. You can measure antibodies by another type of test. So companies like Randox and even some of the vaccine companies in town in Grafton Street and Dawson Street in Dublin are providing antibody tests. I got myself antibody tested early on because I thought I had COVID and I wanted to know whether I did or didn't. And I went for an antibody test that was negative. So an antibody test can tell you if you've recovered from COVID because it measures a response against in a different way than it's not like doing a PCR. PCR only detects the virus when it's in your system, whereas an antibody test will detect it after the virus is gone. You still have the antibodies, so you know if whether you've been infected or not. The levels of antibodies that they pick up in these tests will not tell you whether you're protected or not. It'll only tell you if you have or don't have the antibodies. You really need to be in a research type setting to get the levels of the neutralizing antibodies measured. Even then, there's no recognized level. I had those dotted lines on those graphs that the authors of the articles put on them, but they were hypothetical. There's no measure that says if you have this level of neutralizing antibody, you're protected, but you can guesstimate based on it. But it's not a straightforward test you can go into a Randox and get done, for example. It's something that really has to be done in a research setting.
Okay, thank you. And there's a question as well about how effective antigen tests are. And does a negative antigen test indicate that you almost certainly won't spread COVID-19?
Yeah, I mean, that was part of the opposition to antigen testing early on, that it was exactly that a negative test doesn't tell you that you're not infected. A positive antigen test tells you you're very likely to be infected, but a negative one, it's not 100% accurate in that, you know, as I said, it's more likely to pick it up when you're at the very peak of the virus replication and you're more likely to be spreading it. on the law of averages. But just because you're negative doesn't mean for certain that you have not been infected or that you're not currently infected. You just may have a very low virus load and not able to be picked up by the antigen test, which is less sensitive than PCR. So it's more useful for saying that somebody is infected rather than saying somebody is not infected.
Okay, thank you. And there's a question here about if Ocrevus compromises the immune system, and Ocrevus is indeed a B-cell therapy. So if you'd like to comment on that, Professor Mills.
Yeah, no, I mean, I commented a little bit earlier, but yeah, I mean, the B-cell, I mean, it was a big surprise to a lot of people in the sort of research field that this therapy works so well. And people that couldn't figure it out because they thought it was because the B-cells make antibody, but it turns out, and I was sort of showed in that slide, that what the B-cell does is helps the T-cell to work by presenting the antigens to it. But so the T-cell is the cell that causes the damage, but it's augmented by the B-cell. So if you take out the B-cell's function, you reduce the reactivity of the T-cell. And that's why the B-cell therapy is quite effective, especially in primary progressive MS, where there are not that many therapies that work. In relapsing remitting MS, there are lots of very good therapies. So the B-cell therapy looks very promising from what I've seen. And now, obviously, the downside from the point of view of COVID is it does make people less responsive to the vaccine. But if you're careful and you talk through it with your physician about when you have it, and I'm sure he or she will be able to advise you the appropriate timing. But for me, it's you stay off the treatment, have your vaccine, stay off the treatment for another week, and then get it. And it should be all right. I mean, you still should respond. And in a way, you know, had we not got BA2, you know, I would have been advocating giving everybody with a high risk setting the monoclonal antibody. But now that monoclonal antibody from doesn't work as well against BA2, so it's not the complete answer. Now, it could be that these companies will make Omicron and BA2 versions of their monoclonals, but it'll take a while before they're ready. In the meantime, the antiviral drugs, if people do get infected, I mean, the antiviral drugs will be here, and obviously MS patients would be a high-risk group, and they should be considered for giving these drugs, and they do reduce significantly severe disease and hospitalization.
Thank you. And does being vaccinated impact the period of time that somebody is infectious? Yes,
so that's been shown in a lot of studies now, that even though the vaccines are not preventing infection, they are preventing the extent of the infection. So what happens is that people who are immune, you get a burst of virus, and then that sort of dies away pretty quickly. And they have a much more transient illness than somebody who hadn't been vaccinated or previously infected. So yes, they do shorten the course of the infection, even though they don't completely prevent it.
Thank you. And could you comment on the role of vitamin D and immunity?
B or D?
D.
C.
D.
Okay. The only vitamin that I would have any confidence has any impact, certainly on MS, is vitamin D. All the other, benefits, possibly vitamin A, which is in, root vegetables and green fruits and vegetables, because vitamin A and vitamin D, both of what they do is they help the regulatory T cells, the regulatory responses that control the pathogenic cells in MS. And there was some suggestion early on that vitamin D might also be beneficial in COVID by, again, the same mechanism, but not against infection. I'm talking about against disease, where it's anti-inflammatory, effectively, vitamin D. So people were taking high-dose vitamin D, and certainly there's no harm in it. And if anybody has osteopenia or osteoporosis, taking vitamin D with calcium is a good idea anyway. So it won't hurt you to take vitamin D. And there was a trial done in Vincent's that I was peripherally, superficially involved with in MS patients with high-dose vitamin D. And there was some benefit in terms of reducing these Th17 cells. So vitamin D certainly is a non-toxic therapy, but it's really a food supplement, not a drug, and that's why it doesn't need drug approval. You can go into your pharmacy and buy vitamin D across the counter.
And thank you. I'm just going to go to the Q&A box here now. And I see one comment, Professor Mills, thanking you for your excellent presentation and for your advocacy for the medically vulnerable groups to date. So I think that's shared by many people who are watching here this evening as well. So thank you very much. A question here about, for people on monoclonal antibody therapy such as natalizumab Tysabri, what implication does the mode of action of this treatment have for the effects of active COVID infection, given that Tysabri inhibits T-cell migration to the central nervous system?
Yeah, I mean, it also inhibits T-cell migration to the lung and nose, where you need them to fight the infection. So that's part of the problem. And that's what I was sort of alluding to with that last slide on my talk. You know, it's not been proven, but there's a theoretical risk that blocking migration of cells, either from the lymph node in the case of Fingolma or Guinea, or through the barrier. So Tysabri not only blocks blood-brain barrier penetration of the T cell, but it also blocks penetration into other tissues such as the lung. And it's been used, in fact, to treat Crohn's disease, which of course is a gut inflammatory disorder, because it does the same thing there. It stops the T cell, the immune cells getting into the gut tissue where they cause the inflammation. So there's a generalized effect of that drug. It's not just on the brain. And so it will potentially, theoretically, reduce the ability of the immune system to fight the infection. But that's to fight the infection. Sorry, let's just specifically finish. What I didn't say was that to fight the infection, if it's in the early stages of the infection, but in the later stages where you're starting to get disease, if it was pre-Omicron, then it actually might be beneficial, because then you want to quell the inflammation, and those drugs will quell inflammation. So it's a timing thing. Some of these drugs mightn't be so good for the early stages of infection in that they're taking away the T cells that fight it, but they might be good in chronic or more prolonged disease where the inflammation is bad news. So it's a timing thing.
Thank you. And there's a question in from somebody who is wondering if they should go back to frontline work while they're on Ocrevus and COVID is still around, or whether they should continue to work from home.
Well, I mean, you know, I mean, I as I said at the beginning, I'm not a medic, so I can't give medical advice. But you know, common sense is what I've always advocated in all of this in the last 2 years, using your common sense. If you can work from home and it doesn't compromise your ability to work from home, is what I would say. It's not going to, you know, I have people working with me who do a lot of computer work. They're all going to continue to work from home. And partly because they live in Wicklow and Kildare, and it just saves them 2 hours commute per day. But also some of them are people who just don't feel comfortable yet coming back into work. And they may have their underlying medical conditions that they haven't discussed with me. But you know, I would say to you, if you can work from home, continue to do it. But I don't think you should be scared about going out and getting back into activity. This new variant is not deadly. It really isn't. And it is largely upper respiratory tract. You know, I've heard of people who've got severe versions of it. Obviously, there have been people that have died. But the biggest risk factor in this is not people with MS. It's people who have. I'm not saying that MS are not a vulnerable group, so don't get me wrong. People who are obese, people who have cardiovascular disease, and people who have type 2 diabetes are much higher risk from COVID. But that was COVID when it was Delta and Alpha. I'm not sure that we know yet what the situation is with Omicron, and we certainly don't know with BA2. So it's too early to say. I don't think any expert would put their head up and say that I know for certain that Omicron or BA2 is not going to be a risk. But all the data is pointing towards the fact that it's not as dangerous a disease as it was previously, and primarily upper respiratory tract, and therefore not going to cause the sort of severe inflammation and pneumonia that the previous variants caused.
Thank you. And there's a question in here. For people immune suppressed, vaccination is not as effective. I've been based in Germany for much of the pandemic, where they test my immune reaction. I made no antibodies and minimal T-cell response because the med I'm on, and that's after 4 doses of Pfizer. I've been told my bloods look like those of someone unvaccinated. So we have been in isolation for months. Are there any other potential vaccines out there that will likely be more effective in immune suppressed groups, such as the new Novavax?
Yeah, well, I mean, I'm not sure that Novavax is going to be much better, but it's worth trying. The ideal thing were these monoclonal antibodies. I mean, if it wasn't for BA2, I would say, well, your answer is your monoclonal antibody. I would be optimistic that both Regeneron and GSK, and there's a host of other companies as well. There's about a half a dozen companies that are doing this right now. They're making new monoclonal antibodies in the lab that can be infused into people. And the big deal about the monoclonal antibody is this: you're actually sidestepping the need for the vaccine. You're giving the person the antibody that the vaccine would have generated. So if the person can't generate the antibody, you give them the antibody. That antibody can persist for a few months, and then you get another infusion of it. So it's an ideal. It would have been an ideal for this person, because it's a single infusion. It's doing the same thing as an antibody, and it's overcoming the problem you can't respond. But unfortunately, they're just not as effective now as they were before BA2. But I think it's still worth trying them. I mean, the person should talk to their physicians about whether monoclonal antibodies are available for them or not. But there will be new ones coming along. I'm pretty sure of that.
Thank you. And there's lots of questions, to be fair. So there's one here. Hi, Aoife and Professor Mills, currently sitting in isolation, day 5 with COVID. I've had my vaccination and booster round completed, on Gilenya currently. Just wondering, is there any more info on what my immunity will look like after I have recovered?
Well, short of asking your consultant, neurologist, if he can refer you to an immunology lab or some infectious disease center, and to get your blood taken and measure your neutralizing antibodies. There's no other way of doing it. There are research studies ongoing, including ones that we're doing in Trinity, where and with the people in St. James's, that are looking at patients that are high risk ones, and looking at the levels of their antibodies. But these are research studies, and obviously require ethical approval. You can't just walk in off the street and say, take my blood and put it into a trial. So it's there are logistical issues around doing this. I'd say that some countries probably have that as a service. I know the UK are way ahead of us, and it's simply to do with size of the country and the funding that's available to them. They're testing a lot of their patients, and doing a lot of studies on vulnerable groups, more so than we are. We're doing a small amount of it, but not as much as we'd like to be doing.
Would you have any advice for household members of those with MS and other risk factors of how to best protect those vulnerable people while restrictions ease across the country?
Well, I think that the most important thing is the household members all get vaccinated and boosted, because then their risks of getting infected are much lower. So that's the first thing. But again, I think that there's one of the things that struck me over the last few weeks, when I was saying to Aoife before we started the webinar, that a lot of people have been very complimentary to the things I've said in the media over the last 2 years, but in the last 2 weeks that all changed, because I made some comments about retaining vaccine certs and masks, and I got a barrage of abuse from people in social media, and even personal emails and phone calls, because people are fed up, and they don't want to hear that. And I've sort of said, well, look, I've tried to give both sides of the argument. People are fed up, sure. Majority of the public are fed up, but there's a population out there that are vulnerable, and they need to be protected. And the feeling amongst a lot of the public is they just want to get on with things. And you can understand that. They've been restricted for a lot of the last 2 years, and that's pretty tough, particularly on the younger people who are, you know, I'm looking at our own undergraduate students who've had 2 years in university and haven't met each other. You know, so it is very tough. So for the families of the MS people, obviously they've got to get back to their lives as well. So I would say that get vaccinated, get boosted, and if they do get ill, obviously keep away from them, and maybe do the antigen tests. So antigen testing, it's not foolproof, but it will pick up someone when they're in the infectious stage, most likely. So the combination of sensible approach with antigen testing, and then all the rest of the family can, you know, get back to what they're doing.
Thank you. There's a question here from somebody as well who's asked, they said that they've had 2 doses of AstraZeneca and 1 dose of Pfizer. They're wondering if they need another booster. So what I'd say to that person is that is a clinical question, and it would depend on your individual circumstance. So if you're in doubt with that, the GPs have really good guidance on that. So we would recommend that you get in touch with your GP about that specific question. Sorry.
I don't know that they're doing a 4th dose in Ireland yet anyway, so I don't even think it's an option. Maybe I'm wrong.
So for some people, Professor Mills, some people who were immunocompromised, who they feel might not have mounted an appropriate response from 2 doses, were offered a 3rd dose as part of an extended primary vaccination, and they're now at the point of being offered a 4th dose.
Oh, right, okay.
Booster.
Well, I didn't know that. That's useful to know that.
Yeah, so I suppose for that person, and that does depend on different circumstances. So their GP will be best placed to offer.
Yeah, I mean, just to make a general comment on that, without answering this question specifically, you know, the mRNA vaccine boosters after the adenovirus are very effective, and I would imagine that the Novavax is also going to be very effective. After in terms of boosting the antibody response against the original variant. They're all struggling against Omicron, but at least they're giving you some protection against it. So I would say that you know, 2 doses of an mRNA after adenovirus would be, you know, it would really push up the antibody responses.
Great, thank you. And I'm just conscious of time now. We're approaching 8:15. So, Professor Mills, I might just read out some of the comments there that have come in as well.
Yeah.
And it is just in support of you, really, to say that people are very sorry to hear that you've received abuse for speaking out in support of.
Well, it's par for the course. I mean, if you stick your head out and you're going to go on the media, I suppose you have to accept it. But
and certainly there's great support there, and from people in saying that there is a need to keep you know, the masks and to take all, I suppose, reasonable care. So that's an important thing. So, you know, people with MS being able to protect themselves and being able to take those the tools that we've been given over the past 2 years. I suppose we've learned what we can do to help ourselves, and it's just a matter of maybe sticking with those things now and seeing how things develop.
Pan out. Absolutely.
Yeah. Okay. So look, Professor Mills, thank you so much for your time this evening. I'm going to stop it there, and we really appreciate you coming on and giving your time to us this evening to give us so much information. It's much appreciated. To everybody whose question I didn't get to, I'm very sorry. We did try and take as many as possible, and to try and group some of them as well to answer as many people as we could. Thank you very much. And again, this will be up on our YouTube, on our website, and you'll probably see it on social media as well. So thank you to everybody for joining, and Professor Mills, thank you again.
Thank you, Aoife, for organising it, and I'm delighted to do it. Thank you.
Thank you. Bye now.
Bye.